So welcome back everybody to the monthly AVH webinars. It's great to have you here, and it's a pleasure to welcome back Dr. Gregory Pays, a naturopathic physician who works with homeopathy and uses the Hahnemann's advanced methods of the sixth organon. And today we're going to hear more about the Q, potencies, and medicinal solutions, and then we'll get to have a little bit of a more open discussion. So please take it away, Gregory, and thank you again for being here.
Thanks, Dr. Jeff. I appreciate it, and also appreciate the opportunity by the AVH to have me on with another webinar. For those of you who haven't participated in my couple previous webinars, just a short little bit about who and where I am. I'm a registered naturopathic doctor in practice currently outside of Boulder, Colorado, in a town called Nederland. I've held my DHA and P since 1997, and my practice is a human practice. But for the last 20 plus years, we've had Nubian goats and Angora goats and 2 or 3 varieties of sheep and border collies and Maremma guardian dogs. So I've had a great opportunity both to practice on our animals and actually learn a lot from that homeopathic practice with my animals. What I wanted to do today, and please everyone that's listening, join in with questions. Don't be shy or bashful. Most likely a question you have, even if you don't share it with us, is a question that someone else has as well. I do have a few questions, and they come from other practitioners that I solicited some questions for today's webinar, as well as a couple of other homeopaths, and then from my students from my Hahnemannian posology and practical case management class. So that's where these questions that we'll see we'll be going over, that's where they've come from. Just to ground ourselves and where we're starting from, the information that I draw upon, that I base my practice on, comes from the medicine of experience, my own experience as a homeopath in the last 25 years. But certainly from the organoid of medicine. You see here on the left, the not so great cover there is the 4th edition, which just a shout out if anybody has a PDF copy of the actual 4th edition, not the one where they added 5th edition aphorisms to the 4th and didn't tell us that that's what they were doing, not that one. But if you have an actual PDF copy of the 4th edition that you want to share, I would truly love to have a direct copy. On the right there, you see the 5th edition that was published in 1833, and this is the translation from by Wesselhoff from the German edition. And then, of course, the 6th edition of the Organon. This particular one is translated by Borky, and actually was not published until 1921. For those of you not familiar with the process there, when Hahnemann died, or about a year before he died, he had finished the manuscript and let his publishers know that he was ready to submit the manuscript for them. Melanie, I don't know how accurate this story is, but supposedly Melanie wanted $50,000 US at that point to have the 6th edition published, and no one was able to provide that money. So it wasn't until 1921, and I believe 1922, that we actually had an English edition of the 6th edition. Consequently, most of our great masters of homeopathic practice, Lippe, Kent, Dunham, Guernsey, etc., Herring, all of these wonderful homeopaths that we use their work still after 100 years plus, most of them didn't have, they really didn't have any access to the 6th edition. The only homeopath Hahnemann shared his most recent and current work with before he died was Bonninghausen. And actually Bonninghausen was the main person that was trying to get Melanie to allow the 6th edition to be published after Hahnemann's death, but he was unsuccessful at that point in time. And it was actually from, I believe, Bonninghausen's family that Borky obtained the rights and was able to get the translation that he did in 1921. The other resource for this material is a couple of different editions of the chronic diseases, the one 1835 and the edition in 1837. There's some parts of the introduction in the chronic diseases that's quite useful and descriptive of the medicinal solution, in particular, not so much the Q potency, but how Hahnemann was changing his approach in terms of medicinal solution, repetition of the dose, etc. And just a brief comment here, I will be using the term Q potency to stand for the 50 millisomol potency. I've trained myself not to use the term LM potency. It always bugged me that, knowing Roman numerals, that LM actually stood for 950. It doesn't stand for 50,000. That was an error, I believe, that was introduced by Dr. Fleury. He was the Swiss homeopath that introduced the 6th edition of the organon, really that practice from the 6th edition to homeopaths in the beginning of the 20th century. And it was his favorite term. And so consequently, most homeopaths use the term LM potencies, and certainly I use that for many, many years. But as I say, I've tried to train myself to step out of that, as it has always bugged me that it truly was incorrect. So there are some conditions that we want to consider, and that actually Hahnemann said needed to be in place to apply Q potencies and the medicinal solution. In other words, his perfected method, as he called it. First and foremost, of course, is that the remedy chosen has to be perfectly homeopathic. In other words, not a wrong remedy or a partial simillimum. Notice he says perfectly homeopathic. Not that the remedy has to be perfect, but that your utmost attention is paid to the law of similars, and that's what you're basing your prescription on. Then the remedy needs to be potentized and dissolved in water, not the dry dose. Starting in the 5th edition of the Organon, Hahnemann talked about dissolving remedies in water and states that this is truly the best way to dose medicines. He left behind the dry dosing of the 4th edition that was published in 1829, and of course the previous editions. He left that behind by the time he got to the 5th edition. The remedy also needed to be given in a small dose. And one of the 2 or 3 options that he writes about in the 6th edition is taking 1 pill, certainly as he states it, rarely 2, and placing that pill in a 7 or 8 tablespoon medicinal solution. And then you give this in a split dose, or you can give it by action. And then the remedy can be given at suitable intervals based on what experience has shown to be best. And that experience is your experience as a homeopath, the medicine of experience, individualizing your choice of remedy repetition, not by some rote that somebody has stated in a book, but by how your patient responds and how each patient responds. Even if it's the same pathology, the same person, the same animal with the disease label, you don't give the same dosing frequency just because of some standardized approach. Lastly, but certainly not least importantly, the degree of potency must be changed before administering each dose. In other words, this medicinal solution must be succussed prior to ingestion. By this means, Hahnemann was changing the potency slightly before each dose, and thereby preventing the lack of response by the patient. In other words, in his terms, as long as you did this, you change the potency slightly each time you give a dose, that it is best received by your patient, but it also gives you the flexibility in the process of how often you repeat the dose, and then going up in potency, etc. So these are the 5 central conditions that you want to have in place when you're applying this method. I don't know, excuse me, Dr. Jeff, if there are any questions that have come in just from this part, but before we dive into the questions that I have already, just wanted to see if that sparked any question or concern with anyone listening.
None on this end, but I can't see if there are any questions from Henrietta, Richard, Stephanie, or Sue. So, everyone okay?
All right.
Richard?
All right, good. We'll go on. Oh, I'm sorry. Go ahead.
Oh, I thought Richard started to say some. So, I guess
All right.
we'll see.
So this is a question that comes up with my students, and the idea, I think it's because they've transitioned, or they're trying to transition from the dry dose and wait method to the flexibility that the 5th and 6th edition approach has, such that they really have this question all the time, it seems, how often should they be repeating the dose? And my short answer always in response is individualize. But then, of course, how do you do that? For me, it starts with the assessment when I have in working with the patient initially is what's their level of sensitivity? And some of this I just judge by their story as they tell me their case. I'm taking their initial case and I'm paying attention what they happen to mention along the way in terms of when they've worked with other forms of medicine, be it allopathic medicine, perhaps, or herbs, chiropractic, herbal medicine, acupuncture. Oftentimes, as a naturopathic doctor, and certainly as a homeopath, I'm somewhat the last gasp, meaning that people go through these other modalities and then they get to me, such that they'll say, they worked with an acupuncturist or someone practicing Chinese medicine, and they had this kind of response, or they can't take any drugs for their diagnosing condition because every drug they take, they get all the side effects. So clues like that will help me get a sense of where their sensitivity level is. Certainly, vaccine history is important. It doesn't come up with all of my patients, and for that matter, oftentimes it doesn't come up with my adult patients at all. It's more likely to come up with my younger patients. And I think partly the reason why it doesn't come up so much with adults is they're just not thinking about it at that level, unless they've had a recent vaccination, perhaps like a young woman that's had an HPV vaccine, for instance, recently. Then it might be more on their mind and more in their perception of if they've had any kind of reaction to that. Another aspect of that I roll into sensitivity here is what's their pathology in terms of how serious it is on a tissue level, a functional level, organ level. By this, I mean Crohn's disease, ulcerative colitis, proctitis, diseases like that can have severe, significant flares that, in some instances, severe excessive bleeding, not necessarily life-threatening, but it can certainly put people in the hospital, in the emergency room. So that's what I mean by consider their pathology. A big one that I work with here is their history of drugs that they've taken and how they've reacted to those drugs. And for me, what I mean by suppression is, if, let's say I'm working with a child, I'm thinking of one of my younger patients who no longer works with me. His history was that he had a diagnosis of asthma and was on a daily inhaler, your standard albuterol inhaler, as well as most of the time when he first came to see me, nightly steroid breathing treatments, and that was his level of pathology. At least as far as the conventional approach was, they were pretty much pulling all the guns. And it was my expectation that there, in his history, he started working with me, that as we worked together, and hopefully he had a positive response to the homeopathic medicine, which he did, that some of the symptoms that quote unquote had gone away in the past with the albuterol treatment and the steroid breathing treatments, that they might come back. And certainly in his case, they did. He had a pretty significant history of winter colds, bronchitis, and that's where especially the steroid breathing treatments would come in. And, he would pop a high fever, get bronchitis, and being that this was conventional approach, he'd go to the emergency room and get steroids, and then eventually the treatments at home for this. Such that when I talked to the mom initially, I let her know that potentially some of this would probably come back if we saw a good response to the homeopathic medicine. In other words, his respiratory system and other aspects of his health actually improving under the effects of a homeopathic remedy. That if he got a fever, I would be really happy. And I would let her know that I would really, that I was happy that he got a fever, and that we would do everything we can to support him through that process. But I let her know from the get-go that my approach would not be to suppress the fever, either with over-the-counter meds, or for that matter, quote unquote, natural therapies, herbs for fever, such that I wanted her on board because of my almost expectation that this would happen. And indeed it did. His homeopathic medicine, I believe the initial one we worked with was tuberculinum in Q potency. And even initially had quite a good response. But it was about 4 or 5 weeks later, if I remember correctly, after that first initial visit, so right before his first follow-up, that he did have the onset of a fever and bronchitis, and we worked him through that. And I already had prepared her, for this, these symptoms coming back up again. And certainly one of the tools it wasn't the only reason why I chose to work with the tuberculinum in acute potency. My experience of working with other children, and for that matter, other adults with asthma, had me set up to prepare for this possibility. Secondly, I don't guess how often the patient needs to dose. And this is really important. I see homeopaths that I truly value. They're my teachers, they're my mentors. They know, they're brilliant homeopaths. And they send their patients out the door with daily doses of a 30C oftentimes, 2 or 3 times a day for days and days, weeks on end sometimes, and they get excellent results with their patients. But I'm always waiting for the other shoe to drop, because I've also heard the stories of, again, really well-known homeopaths treating their patients, and the follow-up is, I gave a great remedy and the patient was suicidally depressed for 2 weeks. This is literally what one of these homeopathic teachers presented in one of his cases in a conference years ago, and he was quite content that the patient had a great response, amelioration to the remedy, but it wasn't before he went through this 2 weeks of being suicidally depressed. So I don't automatically send patients out the door, 1, with dry dose remedies, and 2, just saying take a Q potency every day for the next 3 weeks and then get back to me, or take a C potency in water for the next 5 days and then get back to me. With a new patient, I tend to almost always do what I call a test dose. And this is something I learned from David Little, a homeopath who's written extensively about Hahnemann's advanced methods. It's just a way to judge further how a patient's going to respond to the remedy and the potency that I'm using. Because even though I've made the attempt to judge their sensitivity, maybe I got it wrong. Maybe I wasn't paying enough attention. So I'll have the patient do a test dose, whatever it might be in terms of the amount and how many succussions. And typically I have them check back in 48 hours. I let them know, if you want to check back before 48 hours, great. But what I'm looking for is some sort of significant effect, mental, emotional, physical, energy, sleep, whatever it is, but something that changes after that one initial dose. And most of the time, people are content to wait that 48 hours and check back. Sometimes they jump the gun, like one of my patients did today. And it's a new patient I'm treating for chronic UTIs. And I just let her know that, the spectrum of what we're considering, the context. And, she's going to get back in 48 hours like I asked her to. So I don't guess here. And I think that's really important, because let's say that the patient checks back, the one I just mentioned, and she says, well, nothing happened the first day. And it really wasn't until the end of the second day that X happened. Her sleep got better. She felt better overall. Maybe the chronic urging that she's had every day for weeks toned down a little bit. But it took really that 48 hours to see anything move. So that tells me that, at least initially, I'm not going to have her dose any more frequent than every 48 hours. So I'll let her know, please dose once again and check back in 48 hours. And I might do this 1 or 2 times, 3 times in the beginning, just to see where they're at. And if it's consistent that after those first couple of doses that she's actually truly responding every 48 hours, that her symptoms begin to come back, then that's what I'll say, dose every other day for the next week and check back after a week. So I'm in pretty good contact initially with new patients. This, can change and gets shortened and condensed when it's a patient that they're working with for a long time with chronic disease like MS, something along those lines, where they know the process, they're familiar with it. So there's not quite so much back and forth that needs to happen with someone like that, because they're familiar with how we work together. But I think truly, this idea of not guessing is really important, and that's how it's going to tell you to, when you repeat the dose. The other end of the spectrum is last year I saw a new patient with a chronic sinus problem, and it was a pretty easy case of sciatica, at least I think it was. And I had her do a test dose, and she checked back in 48 hours. And I'd say probably 90% of her presenting symptoms were gone with that one dose after 48 hours. And that was one dose of a 30C muriatic in water. I believe 1 teaspoon, probably 5 succussions. And I just kept, I let her know, okay, we're going to wait and see, because this is a significant improvement. We're not just going to repeat the dose. And I had her check back and check back and check back. And I actually presented this case in the pathology class that I did. And I believe it was 62 days before her symptoms began to relapse. And we were in good enough contact. And actually, there was a 1 month, in person over the phone follow-up during that 62 days. And she truly didn't have any relapse of symptoms during that time until after that first follow-up. And I counted it out for my case presentation in that course, and it was 62 days. Now, as I said, that's the extreme. That's never happened to me in 20 plus years of using this method, that somebody responded that well to a single one dose in the beginning. Hahnemann talks about this happening, and I know that the possibility is there. I've seen it happen shorter, 1 week, maybe 2 weeks, but not 62 days. So this idea that, don't guess, I think is truly important, just like Hahnemann emphasizes that it is. A third condition here is you want to ask yourself, in terms of knowing when to repeat the remedy, was there a similar or a dissimilar aggravation after the dose? If a similar aggravation, meaning that the symptoms the patient presented with that you prescribed upon, those are the symptoms that got worse, and you have to be pretty detailed with your questioning of the patient, then that's an indication that your potency selection most likely was too strong for the vital force. So you want to work on modifying your dose to address that. If it's a dissimilar aggravation, meaning that symptoms that the patient has not had before or what present after the dose is given, that's more likely an indication that you've got the wrong remedy. Now, obviously, you want to explore both of these possibilities in depth and question your patient and really not accept general answers, to dive down when you're questioning them so that you can identify whether it is indeed a similar or a dissimilar aggravation. But I think this step is either ignored or missed by many homeopaths, and you're missing a great opportunity here to manage your case and see better results because you're better able to manage your cases. And then really the fourth is that you want to be sure to modify your dose when you've considered all these factors. And these are, you know, the more common ones that I consider. There are probably others, but if you start here, I think you're starting in a good place in terms of knowing when you can repeat and not repeat the remedy. What about here, Dr. Jeff? Any questions at this point?
Not that I saw from the attendees. I again can't see the staff. So anybody have any questions? Anyone that's unmuted? Okay.
Do they need to unmute themselves, or can they just write them in and submit them that way?
Yep. Nope. They can type. The attendees can type. Actually, everyone can
Great.
type in your questions. The staff, the panelists are all unmuted, and everyone can, all of them can unmute themselves. Just hit unmute. So I did have a question regarding the test dose, if you don't mind. Did you ever observe a triphasic response to your test dose where they got better right away, then seemed to get worse, then gradually got better?
I don't think I've seen that with an initial like remedy to a patient dose. I definitely have seen that occasionally with, you know, a follow-up dose, typically of a different medicine. Not necessarily somebody that maybe unmuted themselves, maybe need to mute. They're gonna mix up their drink while we talk here.
Yep. Judy, we're getting a lot of background noise for some reason. Sorry.
So Jeff, it's
you know,
Susan. Are you talking about a similar aggravation, and then the aggravation subsides and the individual continues to improve?
Well, usually what I've observed are usually changes in the beam, one of the beam symptoms, behavior, energy, appetite, or mood. So not necessarily what I would call a similar aggravation, but I guess it when you think about it that way, it could be, but then it would make it more difficult to explain why you see an initial improvement, then worsening, then improvement after that.
You get worsening in your behavior and stuff, or you get worsening in a physical symptom?
It could be either or.
Okay.
And Gregory, you've also observed this, and I'm wondering if you've thought about how, philosophically to explain that.
One thought I was going to say is that something I would look at would be some sort of antidoting of the homeopathic medicine, because that's a subset of when I have seen what you're describing. In other words, something that patient does after initial treatment that changes their remedy response. I have a clear memory of one family, probably at this point almost 20 years ago. The mom and two kids were doing great on 3 different remedies, and then seemingly suddenly all of them at the same time stopped responding to the remedies. And after going through things, I finally asked them where they were storing their homeopathic remedies, and Mom was storing all 3 of theirs on the microwave in the kitchen because it helped them remember to take their remedy. And once I had them, not do that anymore, and away from the microwaves, and they each of them, almost immediately started responding to their remedy again. So, granted, this is a subset probably of what you're seeing, Jeff, but I definitely seen that more than once, that there's been an anhedoning factor that's caused that kind of response.
Gregory, we talk about how microwaves can neutralize remedies or whatever it is we say that they can do. So you've got this remedy parked on top of the microwave. So you were getting temporary antidoting, if you will, whatever that word is, or temporary immobilization of the remedy that actually, when you took it off the microwave, it sort of refound itself again and was able to communicate in the same dynamic, right?
Well, being that this
I mean,
is
that's
20 years,
that's a whole different
right,
question, than microwaves kill remedies.
I don't remember whether I just had them remove it. I think I had, because this was back in Pennsylvania. I believe I had the mom. She either had other pellets for all of them that she had them on hand, or she came back to the office. I don't think it was just me removing. I just assumed that it was, all 3 of them were quote unquote dead at that point.
Yeah.
And I had her mix up new medicinal solutions for all 3 of them from new pellets that hadn't been sitting on the microwave. And then after that, those remedies were not stored on the microwave. So
okay, thanks
I'm
for
pretty
that
sure
clarification.
Yeah. That was a great question. Whoever asked that question about whether you were seeing a similar aggravation, Jeff, I think that really kind of cuts to it, as far as what was going on.
Thanks.
All right, so let's go to, this is one that, who asked me this? Oh, I know. It was, this question came from one of the folks who attended one of the NCH webinar that I did back in July. And she wanted to know if, all potencies, quote unquote, needed to be given in water. And specifically, she was asking me about, like, the X potency, decimal potency. And, I had to think about that for a moment. And my first thought was, well, Hahnemann writes about the superiority of the medicinal solution back in the 5th edition, which was published in 1833. This was 5 years before his first Q potency prescription, which was in 1838, and 9 years before he finished the manuscript for the 6th edition, which was 1842. So he was writing about it back then. At that point, he was in 1833. We know he was using the 30th potency. We think there's some references that he probably used the 200C and possibly the 1M at that point. So what we don't know, because the decimal potency wasn't in existence at that point, we don't know specifically that he would have used the X potency in water. But I don't know why he wouldn't have if it had been available to him. So I think if you want the most control over the dose that you give and the best patient response, the medicinal solution is your friend. In other words, with the medicinal solution, you can control the amount that you give. You can control the succussions that you apply to the solution before you dose. You can dose in a glass, and then a second glass, and a third glass, etc. There are these, these different opportunities to modify the dose that you really, other than, giving more than one pellet, and perhaps more than once today, that's really all you can do with a dry dose. And for most people, if they, at least how most folks have been trained till the 21st century, in other words, the 20th century, people were giving one dose dry and waiting. That was the standard American teaching, at least that I was exposed to back in the 80s and 90s. And that what comes out of Kent specifically was his idea that that people took, that it didn't matter how many pellets you gave. What I've heard described as the oops method. You tap, however many pellets fall into the vial lid, and then that's what the patient takes, right? So, under those circumstances, you don't really have a lot of control. And then I think just some of the mindset is it doesn't, quote unquote, doesn't matter whether you do one pellet or whether you do more than one pellet. And certainly in my experience, that is not true. And that was Hahnemann's experience as well. So then, of course, the question becomes, when do you modify the dose? In other words, once you've found the amount that you've given the patient, how frequent they're taking it, how many succussions they're doing before they take that dose, when do you modify it? What comes up, or what brings to your attention that you might want to modify the dose? And for me, these are some of the issues that I pay attention to. Hypersensitive patients is probably at the top of my list right now, because I just made a mistake the other day with a homeopath who's a friend of mine, who I was treating for a pretty serious rib injury. She was in a lot of pain, and she told me that she was sensitive to homeopathic medicines. And for some reason, somehow, that just went right through my brain, one in one ear and out the other. And I had her start with 1 pellet of it was Nux vomica was her prescription, in 4 ounces of water. And I had her, I said, take a 1/4 teaspoon, and I think I told her like 3 succussions. And she reported back that with that one, after that 1 dose, she had significant muscle spasms, and she was really chilly, and even more so than she had been. And both of those symptoms were symptoms that were part of my prescription of the Nux vomica for her case. So, I knew, and I was like going, duh.
Gregory, you're saying similar aggravation, right?
Yes, exactly.
Yes.
Right.
Just to make the point.
My interpretation of what happened.
Yeah.
And so, to me, that says, the potency was wrong, quote unquote. The potency was wrong. I was pretty sure of my prescription, so I wanted to change potency. So I immediately went to a Q1 Nux and had her come by the next day to pick it up, because she didn't have any Q1 potency of Nux vomica. And this time, paying attention to the fact that she told me again that she was hypersensitive, I said, look, dose into a first glass. In other words, I had her take, succuss her 4 ounces solution to have 1 pellet of the Nux vomica Q1 in it. I had her succuss that twice, and I had her take, I stuck with a 1/4 teaspoon and put that into 4 ounces of water, and I had her stir that vigorously and take 1/4 teaspoon of that, what I call the first glass, as her dose. This time, when she responded, and it was actually the next day, she reported that most of her pain was gone. She had a much better night sleeping, because she'd been up pretty much the previous night with all the pain. And even though her job, where she's lifting people, right, that's her day job, even though she had to do that day, and she tweaked her rib that had been so sore and painful, it didn't last very long. And still, by the end of the day, when she was sending me this email, she was doing very well, just from that second dose, that dose of the Nux vomica Q1 from the first glass. So, to me, that's one of the main things I react to when I have a hypersensitive patient, and not always necessarily using a Q, but certainly the method with the dilution and the succussions and going to a glass. That's pretty much my approach, again, based on how Hahnemann lays it out in the 6th edition. Another reason why I might think of modifying the dose is the flare of serious physical pathology. I mentioned that young boy with asthma that was so, coming into my office for the first time, had been so sick. So he was one that I paid a lot of attention to and fine-tuned his dosing with the Q1 with the tuberculinum, such that I wanted to be as sure as I possibly could that he wouldn't have an aggravation, similar or otherwise, with the tuberculinum. And actually, he never did, working together with me. Another possibility here in terms of modification is what's happening with polypharmacy, meaning that my patients that are on multiple drugs, or for that matter, one drug that I feel might be, quite disruptive if the patient changes it on their own, which many times patients do, even though I clearly and emphatically tell them not to. They still end up, getting rid of their blood pressure meds or stopping their steroids or whatever they're doing that I've asked them not to do. So in those instances, definitely going to look to modifying the dose of the remedy that they're taking to go kind of like in sync with these changes that are happening when they're, changing the dose of their drugs on their own. Something that comes together, that this idea of longstanding chronic disease and assessment of remedy response, those two tend to dovetail together, because in the case of chronic disease that I'm working with, I have a patient who has, she initially had an acute diagnosis of Lyme disease about 15 years ago, that when she went back to the conventional docs after homeopathic treatment, they told her actually that the diagnosis was wrong because her lab results were normal, and that doesn't happen when you have Lyme disease. 15 years later, she came back and actually had a possible diagnosis of MS at that point. It wasn't clear. It was basically she had demyelinating changes on her MRI. So in working with her and her, what I consider to be longstanding chronic disease at that point, again, paying attention to her remedy response to truly modify the dose in sync with that, depending on whether she was having a flare of her pain or her urinary symptoms or the electric shock sensations that she had, etc. So that I felt as much as possible I could stay on top of that and really manage her case through. We've done all sorts of things: drop doses, first, second, third glasses, olfactory dosing, etc., to get her through times. In particular, she's had a difficult reaction to what are called, these, blanking the term at the moment, but things like MSG, right? Those neurological chemicals in foods that many people react to. So that's where this, as I say, this dovetail of the chronic disease and assessment and remedy response really have to come together. And you have so much opportunity to do that. You're not standardizing, you're not by rote just doing everybody gets the same succussions, everybody gets the same amount. In these instances in particular, I think it's so important to manage your cases this way, because you'll see great response when you do it this way. Otherwise, patients get stuck, they have a flare, that you're not able to address the flare because you're not addressing the dose, and then possibly even lose them to homeopathic care because they go somewhere else. Lastly, suppression of the immune response. And this goes back to, again, I think of that case of the boy with asthma and especially the steroid breathing treatments. Now, by the time they stopped working with me because he was doing well, he had stopped the albuterol inhaler and they had stopped the nightly steroid treatments because they didn't need either one anymore. But still, it would come time, one of his symptoms was worse in the wintertime, and he still would have bronchitis. I think it happened once or twice after we began care. And I felt that, at least in part, this was a a reboot, so to speak. This is nothing scientific here. It's empirical. It's not double-blind placebo controlled. But in my experience of working with patients like this, that we get to the point where the immune system actually has a chance to respond in what would be a normal way to these external threats. And then if we support that response, we can help them get out of the suppression and into just a normal, healthy immune response, which oftentimes by that point is easily addressed either by acute homeopathic medicines, or for me, not even that so much. I use naturopathic therapies like hydrotherapy, working with diet, etc. And most of the time, it's a great combination between those two, the homeopathy and those therapies. So there are other instances where you might want to think about modifying your dose when working with the medicinal solution or the acute potency. But these are some of the areas that really bring it up for me. This is a question in a way that's, I won't say it's dear to my heart, because I think it's really a misunderstanding of what the acute potencies are. But again, brilliant, amazing homeopaths, and I don't say that superfluously, have stated this about the acute potencies. And I think it's in part, their training and experience has been decades using everything but the acute potencies. So they don't really have enough experience to be able to judge it. But the comment is, they're just, it's dismissive. Acute potencies are just low potencies. And so they don't have a place in their practice. For me, I think otherwise. This was the last potency scale that Hahnemann developed. And if there's one thing that is true of the process from the first edition of the Organon through the last edition of the Organon, Hahnemann had this one central goal in mind: rapid, gentle, and permanent cure. And he was always looking to adjust the dose, the potency, the action of the remedy to achieve that. He acknowledged and recognized that there was, as he called it, the so-called homeopathic aggravation. But he also wrote about how the efforts and the changes that he made was to address that very factor. So for me, part of it is I don't think that Hahnemann would have made 1,836 prescriptions of a low potency, which is the record that we actually have of the number of Q potencies that he made between the first one in 1838 and the last ones that he made before he died. Another aspect for me regarding this question of low potency is, the idea of gentle and deep acting. Maybe it's my own limited perspective, but I think I wouldn't have seen over the last quarter century the dramatic changes in patients with, I think, serious chronic disease, MS, ulcerative colitis, Crohn's disease, asthma, etc. If this was a low potency scale that you would just dismiss because they weren't deep acting. Another aspect of this, I think, confusion about whether Q potencies are low is that people try to compare Q potencies to centesimal potencies with the idea that they're the same, except the Q potencies are lower. I mean, that's basically how the thinking goes. But there's at least one huge difference between the pharmacy for a centesimal potency and the pharmacy for the Q potencies, and that's the dilution. Well, actually, there's two. The dilution factor, it's 1 to 100 with the centesimal potencies, and it's 1 to 50,000 with the Q potencies. Right there, that's very important. But secondly, and I think also important, is the number of succussions given before each potency level. The up to 10 succussions before the centesimal potencies, depending on the method that's followed, whereas it's very specific with these Q potencies that each level as you go up, each potency is succussed 100 times as part of the raising to the next level. So the dilution factor and the succussions, I think, are outside of what you would call a low potency.
Gregory, it's Susan. One of the
Sure.
things that I was kind of, because the energy dynamics of it makes sense to me, is I keep thinking of that 1 to 100 versus 1 to 500, and the 1 to 100 is kind of like a pinball machine, you know, where it's in there going bing 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 bing, because there's less room, if you will, for the remedy to act. And if you put it in that 500 space, it's a bigger space, and so it doesn't slop around without direction, but it's gentler because the, you know, there's sort of more room, if you will, for it to work. And it's not like a, again, the image I get is a pinball machine where, you know, you set the ball off and it goes in that really close space really, really fast. And that larger space of the dilution kind of makes it a not softer, but softer, less abrupt kind of thing. And that's what I see, that they work clinically that way.
And, you know, I think that's a great analogy. Simply, you know, it makes me think that homeopaths have become so enamored of the pinball effect, right? Ding, 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 and the lights flash and everything's going off and it's really noisy, right?
It shouldn't be. It should be just
think,
like
oh,
this soft ooze.
Right, you know, my remedy's working because it's doing that. And, you know, whereas on the other hand, my perception has been, yeah, your remedy's working, but just because you're not seeing all the lights flash and all the levers flip and all the bells go off, it doesn't mean that you don't have this deep acting effect, which is, again, what I've also seen with the Q potencies, without all that drama. And I you know, I like not having all the drama. And my patients like it too.
And there's some homeopaths who take great pride in you know, aggravating the hell out of things.
Well, you know, it's like that. I'm not going to say the name. It's like that. I mean, seriously, the fellow came out of that, you know, excuse me, in the middle, you know, at the end of his presentation. Literally, that's what he said. My patient he was suicidally depressed for 2 weeks, and then he got, you know, then he did really well on the remedy. And I'm like, what if the guy had killed himself in those 2 weeks? Would that have been you know?
Exactly.
So that, obviously that's stuck with me all these years, because that was probably 15 years, yeah, this early 2000s that I heard this fellow present that way. And yeah, and that, you know, among other reasons was, you know, has struck me as far as the effect here. The last thing that I wanted to say about this was, you know, being quote unquote just low potencies, is I think what comes up for folks is, you know, what we were just talking about. It's like palliation and aggravation. You know, if you're doing this gentle approach for chronic disease and you're not seeing aggravation, then, you know, there really isn't much going on. And you know, my experience has been different. Hahnemann writes that with the Q potencies, you actually see the aggravation at the end of treatment, because at the end of treatment, by his definition, essentially, there's no longer the disease of the patient to be treated. You just have the medicinal disease of the remedy. So you stop the remedy, you slow down the dosing of the remedy, and if the aggravation goes away, then typically at that point the patient is cured. He's done, right? If the symptoms come back after a few days or a week or 2 weeks, then that tells you that, you know, a little bit more needs to happen, and so then you dose your remedy accordingly at that point. And that, you know, that process definitely steps out of this, is separate from this idea of, you know, the palliation aggravation dynamic that again has been part of the training for, you know, I can speak for myself and the other homeopaths that I've worked with, that, you know, that's part of what we were taught, because like me, you know, they weren't taught Q potencies in their initial training. They were taught, you know, the centesimal remedies. So, you know, that's, as I say, this question isn't dear to my heart, but it does bring up an almost visceral response when I hear people state this.
Gregory, can you talk a little bit about how that looks when we get that aggravation at the end of treatment, because we've got the superimposition of the medicinal disease on the patient whose disease has been surmounted by the response to remedy?
So there's a case of inflammatory proctitis that I treated in a woman about 10 or 12 years ago, and her remedy was argentum nitricum. And I gave it to her in Q potency, and over many months we went up the scale to, I believe it was probably Q6, and she started, and she'd been clear of her physical and her mental and her emotional symptoms for a pretty significant period of time. Again, I don't remember the specifics, but it was probably 2 months, and then her symptoms came back. In other words, the symptoms I prescribed upon were decreasing. By this 2-month period of time I'm talking about, they were, practically for all intents and purposes gone.
In the face
And
of in the face of exposure to remedy, correct?
Yeah, correct. Yeah. And then within that time period, began to come back, and I was like jumping up and down, because it literally was the first time I'd seen that. And I said, look, I told her, it's what excites homeopaths. I said, this is great. This is exactly what the way it's supposed to work. This is a great indication that once we're going to stop the remedy here, and you're probably I don't know if I said done, but she was done. And she happens to be one of the few patients that went back to and had more diagnostic imaging done. And whereas her diagnostic imaging had been quite indicative of her diagnosis, at that point her diagnostic imaging indicated that she no longer had the inflammatory proctitis that she'd come to see me for. And of course, she hadn't taken any prescription medicines that they prescribed for that, which really don't do anything anyway other than suppress the symptoms, such that that was the end of her story. And but that is truly the only time I've seen that. And this is something I've been thinking about lately, and wondering, I don't have an answer for why that is. I've had other patients that I've used Q potencies with, and we both felt that they were finished, that their chronic disease was dealt with, and they were in a healthy space. But I never, I just haven't seen it beyond this one.
Do you think that that's because they sort of need to kind of sit and recalibrate with where all of those things are, or do you think that that's because they're not cured totally, and something else is going to happen, not happen, but
Right.
be revealed?
That's the question I'm asking myself at this point, Sue. And the answer that I have for that is I don't know. I have a bias towards that they're not quote unquote cured.
Yeah, that would be my sense, that they're just sort of recalibrating and waiting to reveal, like sort of reorganizing stuff and waiting to articulate the next thing.
But I plan, my plan is to really work this out with, that the next time, I have the opportunity to pursue this further, and kind of rework some of this to see if I've been missing something, either with the individual patients or with my understanding and prescription of the Q potencies. So something new to play with it, literally, because I've been working on this. It is a question that I'm asking myself these days.
Right.
Boy, that was fast. I mean, that hour just like zoomed by. I don't know if there's anyone that has any other questions to submit here before we finish. I'm happy to try and answer, but this has been great.
Yeah, no, this was awesome. Yeah, we actually do have a couple of questions, and I have a quick comment about what's on the screen right now about Q potencies and low potencies. And that is just a comment from, I believe it was Bonihausen's Lesser Writings, where he was able to test out Q potency in his patient. His comment was that it acted like the highest of all potencies that he's seen. So yeah, I would agree clinically with you, Gregory, that they do not at all act like low potencies. They act like gentle, sure, high potencies.
But without the drama.
Without,
Ideally without the drama.
right, unless you start twisting this
Three
and
times
right.
a day for a month. Holy heck.
Aggravations on patients aggravate on Q potencies for sure, but yeah, but maybe the better thing is to say with less drama.
And one of the practitioners that is happy with the aggravations reduces the aggravations a little bit in his hypersensitive patients by using and this is beyond I guess the olfaction dose, uses the toothpick dose.
Right.
So the first dose is just a toothpick dipped in the medicinal solution and touched to the tongue just once. And if they do overreact to that, he actually even wipes it off and then touches it to the tongue.
Yeah.
But
I think I've done that. I think I've done that once, just trying to find some lesser, less than a drop. I tried to, then I used what you're calling the toothpick dose.
I think though that's significant really when we start to talk about what kind of power these medicines have. And when you think that you can actually take a drop from the medicinal solution to the second, third, fourth, fifth, sixth cup and take a drop of that or less and have dynamic response in the individual, it's I don't even know. It's just sweet, like just to think about what kind of power is in these medicines and what potential there is when they're kind of appropriately applied. And also, I have to wonder what happens with the folks that go to the health food store. My niece works at a local health food store, and they routinely stock 10M sulfur and 10M, some of the big polytests, and 10M dry for folks to come up over the counter and take them. 50M. I mean, she sent me an email one night and said, like, what's a 50M compared to a C? And it's like, holy hell, you've got a 50M sulfur on the shelf where anybody can come in and pay $10 and buy a whole box of it?
That's kind of insane.
Yeah.
Never heard that.
All it takes is one person to have an aggravation. Boy.
Yeah. But no, there's just like this amazing subtle sweetness with the art and science here,
Definitely what keeps me going.
Yeah. Yeah.
So that brings me to a comment that Richard made, where he said, and I'll just read it, that I've been using LM potencies since the 80s, and in all honesty, I can't come to a conclusion that there is a noticeable difference between using the LM method versus single high potency 10M, CM, MM. I keep looking, but still no conclusion.
And that's something that I've wondered, because as I said, there are many great homeopaths who don't apply this method, and they get wonderful results. And I think to some extent the answer I've given myself is that we all attract the patients that we attract. I've attracted the patients that I have from the beginning and that I've worked with, that I've helped get well. And I know in my practice that I couldn't do without the Q potencies. That's just been proven over and over again. And yet someone else who's never used them, or not in Richard's case, because he's saying obviously that he's used them, but someone else who's never used them has the same response, giving dry dose remedies every day for weeks on end with nothing untoward happening. I don't have an answer to that. I can only speak to my own experience, and certainly I kind of rest my laurels, so to speak. I stand on the shoulders of giants, right? Isn't that what they say? In terms of how I approach working with them.
Okay, a couple of others. If you have the time, I'll go in order. Lauren asked, can you speak a bit about transitioning from LM1 to LM2 as when the LM1 bottle is finished and the patient is doing well on the frequency of repetition that we have individualized?
What I tend to do, if I understand the question correctly, is let's say that I have a patient on Kali carbonicum Q1 and they've been dosing every day and their whatever symptoms I prescribed on are improving. They're not done, but they're improving significantly. And that dosing every day has been determined by how they responded to the remedy. When it gets to the point where they no longer are responding, in other words, their symptoms are not being addressed by the remedy, and I'm convinced that it is still Kali carbonicum, then I will give them the Kali carbonicum Q2, and most often I just have them continue the same. Or, I'll say, keep dosing whatever it is, 1 teaspoon a day, 5 succussions, and do that for, maybe I'll do it for 1 day, maybe I'll have them do it for 3 days, and then check back and just let me know, if anything, what's going on, because I'm looking to see, is there going to be a change in their symptoms? Are they going to aggravate? Is there something else going to happen? And then if they report back and say, the symptoms that were starting to come back with the Q1 are now responding to the Q2 and I'm doing better, then we'll proceed apace with the Q2. I don't necessarily do it only based on them going through a bottle. In other words, I try and get as much out of each potency as I can. So if I feel that, that they're not, that they can still get more out of the Q1 after 1 4-ounce bottle, I'll have them make up another 4-ounce bottle of Q1. And I've done that, quite often. It's not a, it's not a routine as far as it goes, but that's how I address it.
All right, Lauren, please just type if you have any follow-up. Mary Beth asked, when you note what you understand as a return of old symptoms coming up, how do you modify the dosing if you do?
It would depend on what those return of symptoms are, and what the history of the patient is. I may immediately have them stop the remedy dosing if it's something that, it's some kind of a flare, it's a spike in their pain, or they have a history of fever and they get a fever. I might not necessarily, but I might have them stop so that we see what's going on, see what happens. If it's a return of symptoms that is not central to the case or not central organs, it's peripheral, maybe it's itching on the skin or some joint pain or some muscle pain, in other words, not central to the case and not that disruptive to the vital force, I may have them continue the dosing they've been doing and then just check back in more frequently for a short period of time just to see what happens with those symptoms. There's really a back and forth there, so that's why I can't answer specifically, because it'll change based on what they tell me. I might, decrease, so one option is stop, one option is decrease the frequency, everything that we modify, decrease the succussions, decrease the amount, etc., and see what, if anything, is necessary to address the return of symptoms that happens.
And Charlotta asked, I believe you may have answered this, but the indications to go up from Q1 to Q2 or Q3, and does it help you tell the difference between cure and palliation when you go up, I guess?
Right, right. So I don't know that it helps me differentiate those two aspects. I'm thinking of the chronic disease cases that I work with mostly. And so these people, they're obviously they were originally new patients, but these are people that have been working with for longer than, say, 1 or 2 months, such that I'm absolutely convinced at that point in working with them that the remedy that we've been using, based on what they're telling me, is effective and they are responding to it, such that when they reach, so we had this history with this remedy and no new symptoms come up, right? Or no symptoms come up that would suggest a different remedy picture, because there's still, everything is being covered, not just the 1 or 2 things that they might have focused on, but mental, emotional, physical, i.e. the totality of symptoms, such that, that it's only when, what we've been doing is no longer effective, that's when I think of going up to the Q2. And if we go up to the Q2 and they still don't have a response, then definitely at that point, I'm diving deep into, it's not the right remedy anymore. What am I missing? Are there antidotes? Is something else, come into this patient's life such that their response has changed, right? So I'm looking at all those factors with that transition. But generally speaking, it's based on how they're responding, and when that plateaus, then we're going up to the next potency, the next, from 1 to 2 or 2 to 3 or whatever it might be.
Okay. And
Probably
Lauren,
can do one more question here, if that's.
Yep.
If
Lauren just had a follow-up to her question regarding the technical part of if you're out of, a bottle of, say, the LM1 and you start off with an entirely new bottle using a new solution that you make up. Or do you add more water to the original bottle? So do you use a new bottle, or do you add pellets to a new solution? Because it says that if you do that, it's like starting over with an entirely new bottle instead of, starting at the potency as before.
What I have patients do is they, it's the same remedy. So I just have them rinse out their bottle and then take 1 pellet of the next potency, say a Q2, and then dissolve it in 4 ounces of water. And typically, I haven't needed to have them, let's say the previous potency, we figured out, and they've actually cussed the solution, 100 times. I'm making this number up. I don't have them start with 105 with that next potency, Q2. This is a place where I differ. My experience has been where I differ from what Hahnemann writes about, at least in some of his cases. So in a sense, they're starting over, but they're starting over with the same remedy. They're just starting over with the next potency, so a Q2 versus, say, a Q1. So that's how I do it. I'd suggest testing this out in your own practice and seeing what works for your patients. But that's what I found to be quite workable and effective for the patients that I've used Q potencies with.
So you're actually going down a bit in the potency.
Nope. Because even though each time they've taken that Q1, they've succussed it prior to dosing, that does not bring it up to the next potency to a Q2. So no, I'm not going down. They're starting with a Q2. That is, by definition in pharmacy, that is a next level.
You can't succuss a Q1 up past a Q2.
Right. No.
It's not going to happen.
I'm referring to the situation that Lauren asked about, where you're sticking with what you said before was, if they're out of the bottle of LM1, you just make up another bottle of LM1 if they're doing well on it.
Sorry, I misunderstood.
Okay. Yeah.
So even with that, I don't have them. I'm taking, if I have have them continue on with the Q1. And I've only done this, gosh, I don't know how many, very few times. But when this has to me seemed necessary, in the 5 or 10 times I've done this, I've only had them continue with the ones. So I guess, yeah, in that sense, you could say it's starting over. But I guess I don't think of it that way, because they've been using the Q1 for however long they've been using it, a month, 5 weeks, 6 weeks, whatever it is. And I want them to continue with that. And I don't want to go up to a Q2, because I feel that the vital force is still responding to that level of potency. And I want to get all that response. I'm greedy. I want to see all that I can. And so maybe from that perspective, it is starting over, but from how I look at it and what I've seen, we're not starting from the beginning. We're starting from where we left off and just continuing on.
It's interesting, Gregory, because I can remember having a conversation with Hal Williams, who I know you've met, who was a great homeopath and anthroposophic physician, and you know, Hal said that sometimes all the body needs to see is a change in potency, and so if you take, for example, a Q1 up through whatever's in that original solution that you mixed, and then you start again with a virgin Q1, it's enough to see that change in potency instead of having the same potency every time.
Right. That's a great, yeah. We miss Dr. Williams.
Oh my God, yeah.
That's a great point.
I actually have all of his notes, you know, in Pennsylvania, all of his. I've got his library and his remedy collection, and also a bunch of his clinical notes from when he was, I don't have all of his case records, but I do have the stuff when he was doing his Camp Hill stuff.
That would be fun to look at.
Yeah, it is. It's tremendous. It's tremendous. I mean, you know, we get notes from the teachers that say, you know, they want you to go, and I think you need to see Sally this week because her handwriting has changed, or she's drawing different things in art class and stuff. It's really amazing to read his notes.
Cool.
Well, on that note, I think I'm going to say good evening and thank you all for at least my participation to allow me this opportunity. It's been a lot of fun. I love all the back and forth, and there have been some great questions and comments here. So thank you all so much for a wonderful homeopathic evening here.
Thank you for coming. So, thank you all for coming. Thank you, Gregory, Richard, everyone here. The recording will be available in a little bit, and we will see you next month. So thank you all. Bye-bye.
Good night.
Good night.
Thanks, Gregory.
You're welcome.